Good afternoon or good morning, everyone, depending on where you are. Thank you for joining us today for our liver mets and HAI pumps webinar. My name is Zach Getty, and I am the education manager here at Fight CRC. Fight Colorectal Cancer is the leading patient empowerment and advocacy organization in the United States, providing balanced and objective information on colon and rectal cancer research, treatment, and policy. We are relentless champions of hope, focused on funding promising, high-impact research endeavors while equipping advocates to influence legislation and policy for the collective good. So before we get started today, I've got a few housekeeping items that I always go through. We will have some dedicated time at the end of this webinar for general questions, but please feel free to use the Q&A panel to put those questions in when you think of them or if they come up along the way. This webinar is meant to educate as well as serve as a forum for you to ask your questions and start conversations, so please don't be shy. We will do our best to answer any and all questions that are asked, but do please keep in mind that we may not be able to answer specific questions about your treatment or diagnosis during this event. We will have a recording of this webinar available on our site within the next few days, and you will receive a direct link via email as soon as it is available since you have registered for this webinar. We'll also provide a transcript on our site as well for those of you that would prefer to read the information discussed today as opposed to watch it. Feel free to tweet along with us. You can use the hashtag CRC webinar. And please remember to stop by our website at fightcrc.org to check out all of our patient and caregiver resources. We offer a variety of free-to-use online tools, such as our clinical trial finder, which provides a curated list of clinical or colorectal cancer-specific clinical trials. We offer the patient provider finder, which allows you to search for providers in your area with experience and expertise in treating colorectal cancer. And then we also offer Chat CRC, which is our one-of-a-kind interactive tool that can answer your questions about colorectal cancer and related topics. That's available on our site, or you can text it at 1-318-242-8272, which is Chat CRC. There's also our free Community of Champions application where you can connect with other people in the colorectal cancer space and keep in touch with Fight CRC and know what we're up to. And we also offer an assortment of digital and printed educational resources that are all free to request and download. So stop by our site, take a look. If something catches your eye, order something and I'll get it sent out to you. I have a quick disclaimer. This information or the information and services provided by Fight Colorectal Cancer are for general informational purposes only. The information and services are not intended to be substitutes for professional medical advice, diagnoses, or treatment. If you're ill or suspect that you're ill, please see a doctor immediately. In an emergency, call 911 or go to the nearest emergency room. Fight Colorectal Cancer never recommends or endorses any specific physicians, products, or treatment for any condition. All right. With all of that out of our way, I would like to briefly introduce our panelists today. Joining us are Dr. Louise Connell, medical oncologist at Memorial Sloan Kettering Cancer Center, and Carole Motycka, Stage 4 survivor, HAI pump recipient, and Fight CRC's community engagement coordinator. Dr. Connell and Carole, thank you both so much for taking time out of your busy schedule to join us today. I'm going to hand it off to the two of you to give you a chance to introduce yourselves a little more thoroughly, give us some insight into your background, and then we will get started on Dr. Connell's slides. So Dr. Connell, if you'd like to introduce yourself a little more thoroughly, please.
Okay, thank you, Zach, and thank you very much for the opportunity to speak to you all today. So as mentioned, my name is Louise Connell. I'm an Irish-trained physician, and I specialize in GI cancers, but in particular, in my work at Memorial Sloan Kettering, I'm treating patients with colorectal cancer. And you know, since I came to New York in training, I really found my passion with patients with the HAI program and have taken on the lead in managing that program from a medical oncology side in recent years. So I'm happy to be here today, and thank you for the opportunity to discuss this option with you.
Yeah, thanks so much for joining us. Carole?
Hi, everyone. Thank you, Dr. Connell, for bringing the science to the table first. I mean, it's so important for us as a community to have opportunities to hear novel research that is transitioning into into treatments that are options for us as patients. I'm honored to be able to sit at the table with you today and have this conversation. And also, before I introduce myself and my role at Fight CRC and a little bit about me, I want to take a minute to also applaud Fight Colorectal Cancer. Something that brought me to this organization was its great ability to bring patients and their stories to the table, along with their lived experiences. That the conversations that we have are important with the science, but also with the patient's experience so that we can understand how this looks through lived experiences similar to my own experience. And I'm honored to be able to sit here and with you and share a little bit about my experience, my treatment care with the HAI pump that was involved. As Zach mentioned, I'm the community engagement coordinator at Fight CRC. So what that looks like is I get to connect with the community, which is a really, really enjoyable role. I was a teacher prior to my diagnosis, living the dream as a suburban mom. But in 2016, life turned upside down. I was diagnosed with stage 4 hereditary metastatic colorectal cancer after a hike. I had a sore shoulder and I experienced excruciating pain, and I landed in the ER. And through investigation that I'm fortunate enough to have been a part of, I was able to seek care that was critical and life-saving for me. But before that, life turned upside down. I became a patient in 2016. I was given 6 months to live, and now sitting here as a 10-year survivor, I'm sure most people, myself included sometimes, consider that unfathomable. But it's because of the care, it's because of the community that's here, that exists, and the care that I received. I was also the caregiver to my husband, Mike Mancini, who passed from the disease. And so I'm just proud to be here to sit in this space to talk about my case that was complex. I was part of a multi-site trial, actually at the Cleveland Clinic through Dr. Kemeny, who I believe we all know pretty well in this setting. And so I'm just here today to help answer questions as it relates to everyday life with my treatment. And I think I'm going to divulge a little bit more in depth on that later, but then also with just lived experiences with the HAI pump. So thanks for having me today.
Thanks, Carole. Thanks for joining us. All right, Dr. Connell, I'm going to hand it off to you to talk about the slides you provided, and I'll advance these on your command, so we can go.
Thank you. So this is just a quick disclaimer, just acknowledging some of my work, but that these are really my personal opinions in the presentation today. We can advance to the next slide. So a lot of this information, many of you already know, or perhaps there are patients or caregivers who are new to this disease and starting off in their journey. So I just really want to set the scene with some of these slides, but I think a lot of this webinar, we're going to learn so much from each other with the Q&A and also from listening to Carole's perspective. But just to get down to, some of the background here, colorectal cancer is the third leading cause of cancer-related death in the United States, which is a pretty sobering fact. And over 150,000 patients are diagnosed each year. With colorectal cancer, it is the leading cause of cancer death in men under the age of 50, and also the second leading cause of cancer death in women under 50. And what I always say to the patients who are coming into my clinic, honestly, is that I'm treating patients who are in the same age bracket as myself, and that, there's a drive there to seek these aggressive treatments and really, help improve the outcomes for patients in this patient population. What's very sobering, in fact, is the fact that over 50% of all patients with colorectal cancer will ultimately develop liver metastases. Next slide, please. So what are the treatment options then that we have for patients with colorectal cancer liver metastases? So we have our standard chemotherapy options, which may or may not include various different biologics. And again, these are chemotherapy regimens that many of you have heard multiple times: our FOLFOX combination, FOLFIRI combination, as well as bevacizumab or some of our EGFR inhibitors. It's very important nowadays to check the biomarkers and the molecular profiling of patients with colorectal cancer. And the four main targets that we check for are the microsatellite status, which is important in terms of looking for inherited risk, but also looking for immunotherapy as an option over standard chemotherapy. We check RAS status in all patients, and we do have a drug target in patients who are RAS wild type with the cetuximab and panitumumab. We're now increasingly seeing clinical trials for patients who have a RAS mutation, looking for RAS inhibitor studies. A BRAF mutation is also important to identify in patients, and there are targeted drugs for this patient group, as well as HER2 status. What I always say to patients when I meet them the first time is I'm a very strong believer in chemotherapy and systemic regimens, but also I think how patients do well is intermixing what we have in terms of these drug treatments with local regional approaches when it's appropriate for that individual patient. And so we have local regional approaches for patients who have liver only or liver dominant disease, which should include resection or surgical removal of the tumor, ablation or Y90. These are procedures that are done by our interventional radiology colleagues. I should also mention radiation in this group. And then, of course, the HAI pump, which is hepatic arterial infusion chemotherapy. In patients who have lung metastatic colorectal cancer or oligometastatic disease, again, we would consider some of these approaches such as ablation, surgical removal, or stereotactic radiation. Next slide. Yeah. So if we look at some of the other local regional options available then for patients with liver dominant or liver only metastatic colorectal cancer, one of the common options is to consider ablation. So percutaneous ablation, according to the NCCN guidelines, is recommended as a standalone treatment or in combination with surgery for patients as long as all visible disease can be removed. And it's considered for patients who have what we call oligometastatic disease. So that means that there's a limited number of tumors and they're small tumors. So the honest answer is ideally we want patients where the tumor size is under 3 centimeters. And ablation is universally accepted as a local treatment for patients with colorectal liver metastases, in patients who are considered poor surgical candidates, as well as in patients who've had post-hepatectomy or post-surgery recurrences. With improved clinical outcomes, then ablation has evolved into an acceptable alternative to surgery for patients who have resectable or ablatable disease. And what I'll often see in my patient population is that we may have a combination of surgery with ablation intraoperatively in the patients who are being treated. There are series which show that the 5-year overall survival rates are as high as 47.8%. And there's different forms of ablation techniques out there. These are listed over on the right-hand side. So we have radiofrequency ablation, we have microwave ablation, we have cryoablation, which has to do with freezing of tumors, and we also have irreversible electroporation. To make a decision about what is the appropriate ablation technique in the individual patient, you will have a formal consultation with an interventional radiologist, who's usually the person who performs this particular technique. But again, this is really for patients who have, small volume of tumors and also small size tumors. Next slide. So then looking at Y90. So Y90, there's various different terms out there. This is basically transarterial radioembolization. And what it involves is the infusion of a radioactive microspheres through the hepatic artery in the liver to deliver high-dose radiation directly to the tumor. It's also called SIRT, or selective internal radiation therapy, or inside-out radiation. So the Y90 or yttrium-90 is the radioactive isotope which is used, and the microspheres can be directed to treat an entire lobe or a specific segment of the liver. So what I generally say to patients who are considering a HAI pump, and we can get into this in the Q&A section, is that my preference in general is to offer HAI therapy prior to Y90 and keep Y90 for later on in patients. But, years ago, Y90 was very broad. Now we have really fine-tuned the technique, and there's personalized dosing involved, which means that there's more selective approaches in terms of the Y90 leading to improved outcomes. And we also have ablative doses, which means that it's more limited. So it's not a complete contraindication in a patient who's already had Y90 to a portion of the liver to be considered for a HAI pump. But in general, my preference would be to do the HAI pump first. Next slide. So then moving on to HAI therapy, or hepatic artery infusion therapy. So the hepatic artery is a blood vessel which supplies blood to tumors in the liver. This is a nice animation which shows how the pump works. We described the pump as being the size of a hockey puck. In the clinic, I'll show patients a model of the pump, and it's usually placed down in the lower left belly. If you are a patient who already has a stoma in place, then it can be placed on the opposite side. Again, there can be a little bit of swelling after surgery, but everything is internal. It's all inside the body, including the catheter, which is directed from the pump to the liver. And so if we look at the main differences between our traditional chemotherapy and HAI therapy, traditional chemotherapy is delivered through a vein. So in general, that can be done through a cannula in the arm or through a Metaport. With HAI therapy, it's delivered through this pump, which is implanted below the skin in the abdomen. And it does require a surgery to place the pump, which is important to say, but it's more localized. With traditional chemotherapy, the drug travels through the body's bloodstream to reach the liver. Whereas with HAI therapy, the drug is administered through the hepatic artery directly to tumors in the liver, and it treats the entire liver. With traditional chemotherapy, only a small portion of the drug will get to the tumors in the liver, while with HAI therapy, we're getting very high concentrations of the drug, anywhere up to 400 times a higher concentration to the tumors in the liver. And then again, as many of you are aware, with traditional chemotherapy, side effects can be felt throughout the entire body. Because of the metabolism through the liver, the so-called first-pass metabolism, even though it's a very high drug concentration to the tumors in the liver, there really isn't systemic side effects and limited side effects elsewhere in the body. Next slide. So this is a nice diagram which shows the size of the HAI pump. It is FDA approved. It's PAM sized, but again, as I mentioned earlier, we commonly refer to it being the size of a hockey puck. And it's a patient's body heat, which helps power delivery of the drug. The treatment will flow continuously and directly to the liver, and a patient can go about and continue their daily activities, which I expect will be some of the questions that come up later on, what you can or can't do with the HAI pump. And the pump is refilled every 2 weeks while you're undergoing active treatment. So just to mention that quickly before we go on to the next slide, if you get to a point where you can have a chemo break or you're without evidence of disease and you're off the active treatment, we can switch over to a liquid called glycerol, which basically requires a pump flush every 8 weeks. So this makes, it improves the time off chemotherapy for patients and not having to come back every 2 weeks for a fill. But that's during the inactive phase of treatment. Next slide. So this is the patient's journey. So if we take it to the top down. So, this is a very effective treatment, but a very specialized treatment. And it is important to seek a consultation at a center that has experience with providing HAI therapy. So you will have a consultation with the HAI provider to learn about, what is required and what makes you eligible for HAI therapy. In general, when patients come to see us here at Memorial, they'll have a joint consultation with a medical oncologist and a surgical oncologist. We'll also perform scans to confirm that there isn't any signs of cancer spread outside the liver and that you are indeed eligible for the HAI procedure. The systemic chemotherapy does need to be stopped about 3 to 4 weeks prior to surgery, and it is a surgery to implant the HAI pump. If the pump is being implanted on its own, so there's no plan for an immediate surgery on the liver, it can be done laparoscopically or robotically. In general, however, more commonly, it is an open surgery. And also I mentioned to patients, if you have your gallbladder still in place, we will generally perform a cholecystectomy at the same time that the liver pump is placed. So the pump is filled, you have a stay in the hospital. And in the hospital prior to discharge, you will have a very specific type of imaging study, which is called a pump flow scan or a hepatic flow scan. And essentially, the idea behind that scan is to confirm that the system is contained, that everything is flowing from the pump to the liver and not going anywhere outside. The patient is discharged from the hospital and you have your first pump refill around 2 weeks after surgery. If you have not had any operation on the liver, so you simply have the pump placed, you can actually start the liver drug at 2 weeks. But if you've had some form of surgery on the liver to remove some of the tumors or perhaps all of the tumors in the liver at the same time the pump is placed, then we'll just flush the pump at 2 weeks and you'll start the liver drug at 4 weeks from surgery. The patient then returns every 2 weeks for lab work. Very important to check liver enzymes in our patients and pump refills. And it will be alternating between active drugs, with fluoxetine, with heparin C. Important to mention that if you can't keep your required appointment, you need to call your provider in advance to make sure, number one, the pump doesn't run dry, but also number two, if you have the active liver drug in there, it's very important because it's such a high concentration of the drug that we either remove it on time or we remove it a little bit early. This is preferred to letting the pump stay in longer than 14 days. Systemic chemotherapy then will be restarted at around 4 weeks after surgery. So we usually give the liver drug on its own the first time and then 2 weeks later get you back on your systemic chemo. I also do mention this to patients in that first consult. Sometimes understandably as a patient, you may think that the liver pump will replace your traditional chemotherapy. But in general, we will continue some form of traditional chemotherapy through the Metaport, but it's usually very modified dosing and scaled back so that it works in synergy with the liver pump treatment. You will have continued follow-up care then with your HAI provider. When I'm seeing patients who perhaps we've placed the pump and we haven't been able to operate on the liver tumors just yet, I will scan those patients every 2 months, so after every 2 doses of the liver drug to assess response. In patients where we're using the liver pump treatment after surgery to remove the tumors in the liver, I'll scan those patients every 3 months, so a little bit less. During the HAI therapy, then you need to inform about any travel or activities that you plan to do. And also, in conjunction with your provider, there will be a decision about when to discontinue the HAI therapy and about maintaining the pump. So one difference again between a Metaport and a HAI pump is that if a patient has a Metaport removed at the end of chemotherapy, it can be replaced in the future if needed. With the HAI pump, it's really a one-time procedure. So we do generally recommend that patients keep the liver pump in place for at least 2 years without evidence of disease. I generally encourage my patients to keep it longer than that, but at least 2 years. And that's the time frame that you can have this glycerol fluid, which I mentioned, which means much less frequent trips to the infusion center once every 2 months. Next slide. So what are the applications? So we use, in colorectal cancer liver metastasis, we use HAI therapy in 2 different scenarios. We mentioned it in patients who have unresectable or currently inoperable liver metastases, and the therapy can prevent the tumors from growing. It also helps shrink the tumors to a point that they can then be surgically removed or disappear altogether. And we've shown that this helps prolong survival, even in patients where we cannot remove the tumors. And there are several studies over the years that have shown this. We also use the HAI pump in patients where you can have liver surgery. So after the tumors have been surgically removed, we give the HAI therapy a so-called adjuvant treatment or in the preventative setting. And the concept here is to prevent any remaining microscopic cancer cells from growing into a new tumor. And it has also been shown to help prolong survival, which is something that we have not seen in the adjuvant setting post-liver resection with our traditional systemic chemotherapies to date. Next slide. The studies then have shown that survival is improved, in both unresectable patients as well as in the adjuvant application when HAI is added to systemic chemotherapy. Next slide. So what is the clinical evidence then? So in patients with unresectable disease, we see that the tumor response rate to a combination of the HAI therapy with systemic chemo is high in both patients that are chemo naive, so they have it up front. It's around 86% response rate, and also in patients who were previously treated, so about 2/3 of patients. And these rates of response are higher than what we would see with traditional systemic chemotherapy alone. There's also an important study which showed that over 50% of patients can be converted to resection using a combination of HAI with systemic chemo. And this was despite patients having what we call a high disease burden. So they have like bilobar disease, tumors on both sides of the liver, a large number of tumors present, and also previous chemotherapy. So again, important to mention that this is a much higher rate of conversion than what we've seen to date with even what we call modern systemic, modern chemotherapy regimens. The 5-year overall survival rate then is over 63% for these patients. Next slide. And then looking at after liver resection, so this is the adjuvant treatment that I mentioned, and this was a very important study which was updated in recent years to show sort of longer survival outcomes for patients. And so this is the only adjuvant study, the only study with chemotherapy, whether it be systemic or otherwise, that has shown an improvement in survival basically by using postoperative treatment. So there was a nearly 2-year improvement in median overall survival in patients who had adjuvant HAI therapy plus modern systemic chemo versus modern systemic chemo alone. So whether they had HAI with FOLFOX or FOLFIRI versus FOLFOX or FOLFIRI alone. And we saw an improvement in terms of 44 months to 67 months. So there was a 60% improvement in the probability of cure for those patients seen in the combination arm, which included the HAI with modern systemic chemotherapy. Next slide. I think we're almost there and we get to the interesting part, which is the Q&A. But this is just some information about how you can get some one-to-one information from an HAI education specialist. You can submit a form online if anybody wants to take a photograph of the QR code, where you can have some initial information before you decide to travel perhaps to a HAI center to ask your questions about the treatment, how you, have those conversations with the providers and connecting you to a provider, close to you for an appointment. It's also important to mention that there are a lot more centers now throughout the United States who, can do this therapy. Next slide. And this is just some safety information. I just want to mention very quickly, I think this may be the final slide, is that the pump itself, you can have an MRI with the liver pump. This comes up quite a bit. So it is safe to have an MRI if you need it for any reason, like an MRI liver or an MRI brain. And this often comes up for patients who go to smaller community hospitals. And also with the liver pump in place, it is important that, to consider that it does require a surgery to place the pump. The physical activity question I'll probably leave mainly to the Q&A section, but, there are some modifications in the style that need to be done. You can't scuba dive with a pump in, you can't be in a hot tub during active treatment, but there are many things that patients can still do. And I do want to dispel some of the myths out there about what you can or can't do with the pump. You can travel with the pump. You will be given a little card that you can carry through TSA and show that you have this liver pump in place. And it's always important, to talk to your doctor to understand the risks and the benefits in terms of using this device. Next slide, which probably at this point is going to open up the floor for Carole to speak. Yeah, I've taken up a lot of time, so I'm going to hand over to Carole to.
Not at all. Thank you so much. It's really informative. I have lots of questions, so I'm going to give Carole a chance to kind of share her story because she's actually had an HAI pump, talk a little bit about the experience and all that, and then I'll open it up to questions. So if you have a question, please feel free to go ahead and throw it in the Q&A, and then we can get to you just as soon as possible. But yeah, Carole, if you wouldn't mind kind of sharing just your experience with having a pump and a little bit about your story, I would really love to hear it.
Sure thing. Thanks, Zach. Thanks, Dr. Connell. I want to preface my little piece of information about my lived experience, and that we are all so unique in these experiences. And so what might have happened to me in my setting, in my situation, has certainly, can certainly look different for everyone. My case, as it sat, was a very complex situation from the get-go. As Dr. Connell mentioned, people with high burdens of disease are looked at a little bit differently. Given the extent and location of my disease, I think that that's why my care team at the Cleveland Clinic pursued the treatment strategy that they did with the HAI pump. But I might preface that with saying that I was a mom of four, and I was I was in the prime of my life. I was completely healthy. I had no comorbidities, and I think a lot of those things equal pieces of the the aggressiveness of the treatment of the care team at the clinic. So I think that that looks different in a lot of different settings. So this is my unique experience, but we always approached it. With a curative intent. That said, we began because my disease was a high burden. I had disease presented on both lobes of my liver. The right lobe, as it was too unsalvageable. And so we began with systemic chemotherapy to assess the tumor burden response and then to guide a surgical plan. And my plan really was a carefully staged three-part plan. And so I just kind of will dive into that a little bit, and then happy to answer questions about what that looked like, from a life experience, treatment experience. As Dr. Connell mentioned, lots of infusion dates and fill dates and things like that. So happy to share a little bit about those points. But as far as the three-stage surgical approach for me looked, first I went through 12 rounds of FOLFOX Fury, and that was to assess if my tumors would respond to chemotherapy, so that we could reduce burden before we did any kind of surgical intervention. Fortunately, mine did respond very well. And so we were able to move to the first step in my surgical approach, which was to remove my primary tumor that was in my colon. And then I also had a right hepectomy to remove the right lobe of my liver. That was the first step in my treatment after I had that clinical response to chemotherapy. The next step was where that hepatic artery infusion pump came into play. After the surgery healing, I underwent another surgery in where the HAI pump was placed in my left abdomen, along the abdominal wall in between the muscle and my abdomen. And that I took 10 rounds of FUDR chemotherapy, and that was delivered, as Dr. Connell mentioned, directly to my liver. And I received that over a period of 6 months. And that was, so I homed the HAI pump for 6 months as I received the treatment to my liver, which successfully reduced the tumor burden. And that was our goal, was to try and reduce that left lobe burden, because I had a few very complex tumors that were actually setting in the hepatic arc. And so the concern was with the liver, and we understand, the vascular way that the liver is built. The concern was if they could reduce the tumors at all with the HAI pump, they could also preserve the health of my other organs, and then also get me to the next stage, which is the third step of surgery, a lot faster. So that was the plan for me for the hepatic artery infusion pump, which was wildly successful. I did the 12 rounds. My labs were wonderful. I really handled the treatment well. And I got to the third surgery. We removed the HAI pump. I have it now. It took me about 3 years to actually get my hands on it. But if anybody has any questions about how to work that, message me privately. But the procedure was a success. They removed the HAI pump. I became cancer-free. My surgical burden, the surgical team looked at the burden again and said, we were able to go in and remove the other tumors that were on the left lobe while still preserving enough tissue to sustain a long-term function of my liver. So the result was wildly effective. I didn't have cancer. They were able to remove the tumor burden because of the HAI pump while preserving my overall health. I did not have systemic chemo alongside of the HAI pump because I had already treated. And so that wasn't something that they infused into my my plan of surgical approach. So that's kind of where the intersect happened for me and the HAI pump. I will note that something really important that I like to share is I am also a liver transplant recipient. So in 2018, 2 years later, my liver, that left lobe that we tried so hard to maintain through the HAI pump treatment, finally decided it was really tired. And I went into liver failure due to severe biliary inflammation. And as a result of that, I actually received one of the first living donor liver transplants at the Cleveland Clinic, which was again life-saving and history-making procedure. But I say that only because the HAI pump precluded that by allowing me to get to that space successfully where I didn't have any tumor burden, because the way that transplant is handled is if I would have had tumor burden, it would have looked a lot differently. So for me, that was a big win. Also, in the long-term care of what it could possibly look like in the future, the HAI pump was a huge bridge for me that got me to at the end transplant of a new liver, of a new organ. So that's really where I was and what happened in my experience. Again, I preface that with this is a personal lived experience, and so yeah, happy to answer questions and help with everyday life. Maybe ease the burden a little bit of your fears or questions for the pump.
Thank you so much, Carole. I really appreciate you sharing your story. And thank you both for taking the time to just kind of chat with everyone here today. So I do have some questions coming into the Q&A panel. I also received a considerable amount of questions via email before this event. So I'm going to get to the ones in the Q&A panel first. And then if we run out or if people stop asking questions, I can get to those ones that I received earlier. So the first one I have today is, if in traditional treatment, only a small percentage of chemo reaches the liver compared to HAI, why is the standard of care for CRC liver metastasis still traditional chemo?
Yeah, it's a very good question. I think it's also important to note exactly what Carole said there. We were, initially we know a lot more about understanding about the tumor biology, right? And making sure that we are also selecting the right patients who are going to benefit from the HAI therapy. And what I mean by that is patients where it's liver only involvement or liver dominant, maybe there's a small lung nodule or something like that. So if I see somebody right at the time of their diagnosis, the honest answer is that I want to understand more to make sure that I'm helping that patient by prioritizing high dose chemotherapy to the liver and not at the expense of, spread of disease outside the liver. So checking the molecular profiling, the BRAF status, information like that, and to make sure that this patient is somebody who's going to benefit from a liver directed approach. Because I generally do continue at some form of modified systemic chemo in patients with the HAI pump, but there definitely are providers who do not for various different reasons, which is absolutely fine. But it's a much scaled back version of the systemic chemo. So it's devastating for a patient if we prioritize a liver-directed approach and perhaps put in a pump too early. They go for a planned liver surgery and we find peritoneal metastasis, for example. So there is what we call a test of time to understand that, number one, is this a patient who's responding to treatment? But also number two, is this a patient where the liver is going to be the driver of their outcome, right? Or how well they're going to do. To preface that, what I would say about the HAI pump, though, is I've also seen patients who've come to me who have not responded to traditional chemo. So, for example, they've been started on FOLFOX first line, they didn't get a response. They've had FOLFIRI second line, they haven't had a response. If the disease is still confined to the liver and the liver lesions are what are growing, I have had patients who, despite progression of disease on traditional chemotherapy, have had a response to the HAI pump. So I also don't want to say that I wouldn't put a pump in somebody who's progressing on traditional chemo. I may consider it if I know that over time it's really liver-only disease in that particular patient.
Interesting. So like many other things, a lot of it comes down to the specifics of the situation and really weighing benefit versus risk, and very interesting. Thank you. I have a question from a stage 4 patient with mets to the liver who already has an HAI pump. They ask, how common is it to postpone a scheduled pump chemo session when liver enzymes are too high?
So this comes up all the time. I've learned over the years what to say in the first consultation, and honesty I think is key. So in my experience, honestly, everybody at some point needs a hold or a dose reduction, and it's a little bit variable. But I do tell my patients that like right in the beginning, because I understand. Now, thankfully, there are a lot more centers around the US, but for many years, patients were making huge personal commitments, financial commitments, flying from all around the country, outside the country, to come to me in New York to get pump treatment. And then they come in on a day and I say, I'm not going to give it. So it is very, very important to be upfront with patients and explain to them that this is a very, very real possibility and exactly why we do it, right? So, typically what I've seen in patients is maybe after the second or third dose of the drug, it can happen. It can also happen a little bit sooner. It can happen after the first one. It might not happen after 6, but I do prepare them for that because I understand, as I said, that it's difficult. You've invested a lot in getting a pump in and traveling to have this treatment. And there's a lot of hope involved, right, with having an HAI pump and then not to get treatment. And I think this is where it's very different to traditional chemo, right? Because if you're on your traditional systemic chemo and you have the neuropathy from oxaliplatin or your white count is too low, these are all things that you experience yourself, right? You feel the neuropathy, you feel unwell, and you understand then why the doctor might hold the drug or might delay giving you the treatment. With the HAI pump, what's a little bit different is that in general, the patients come in and they feel fine. They feel absolutely fantastic. They probably even feel better than they have before if they're either not getting the systemic, as was Carole's case, or if they're getting like lower dosing of systemic. And then you come in and I say, well, I'm not giving you the drug today. And that really has to come down with the focusing on the liver enzymes and making sure that we're being safe. So we have a very strict algorithm in terms of dosing the liver pump, that you're getting the response to the treatment, but we're not causing damage. But it's usually a situation where you as a patient have no symptoms whatsoever, you feel fine, and you come and the provider tells you that you can't have it. So it's very different to traditional chemo in that regard. I'm not sure, Carole, did this ever happen to you out of interest? Did you ever need a hold or, yeah?
So yeah, I did a glycerin fill, I believe, third or fourth treatment. To your point, Dr. Connell, it started about the third or fourth treatment and I down dosed, but we skipped one dose and then we just extended. But I had a glycerin fill, and my liver enzymes recovered. They just needed a little extra boost. And then I think we did a steroid alongside of it.
Yeah.
To give it a little extra hand.
If patients are traveling, Dr. Connell, like they're flying to come and see you, is it advisable for them to have their enzymes checked perhaps at like their PCP's office before traveling, or is this we need to know right now, the very moment before we're actually loading your pump with chemo, what your enzymes are and whether or not it's safe to proceed?
It's a very good question. I think what I've increasingly found in recent years, because now we have so many more centers available, typically the patients that I'm seeing now, before they would have been coming to me every 2 weeks for the flush and the FUDR. Now what I'm seeing a little bit more commonly is perhaps the patient is still traveling to me for the FUDR, but has a local provider who can do the flush. So the honest answer is there's a lot of communication between teams, and we generally know at the time of the interim fill, okay, the numbers are a little high, but they're, so just looking at the trend. So if I know what the lab work has been with the interim fill, I can generally say in advance whether or not I think the patient will be okay to come for FUDR 2 weeks later. So to your point, I generally don't get a patient to repeat the labs a few days prior. In very select cases, I might do. But I also have learned, again, because I'm seeing this in a very high volume, if I see somebody on a day and I hold the FUDR, I can generally almost say to the patient at this point, I don't expect you to be ready in 2 or 4 weeks. I think it'll take 6 weeks, So there's two things that we do, which Carole mentioned. Number one is we do put steroid into the pump at the time of the heparin saline fill, which also helps with any liver inflammation. And then in other patients and in many patients, we may also give a medication called ursodiol or Actigol. And this is a medication that helps the liver clear waste products. And that's an oral agent that patients take twice a day. Again, if a patient is traveling a long distance and there is also a lot of financial concerns, it does make sense that maybe a few days earlier you might check the enzymes before they travel, but we would still need to check them on the day of treatment as well.
Good, thank you.
Yeah.
You both may actually have a little bit of insight to this. Can you speak to why some centers allow for living donor transplant after HAI, but others do not?
So I'll give you my brief update on that. Carole knows a lot more than me, but so Memorial Sloan Kettering is not a transplant center. So any of my patients who are considering a transplant, do need to go to an outside center. And we work very closely with centers both within New York City and also around the country. A liver pump, as Carole already said earlier, it is not an exclusion criteria for a liver transplant. There are some centers that are a little bit more hesitant, I think, than others, but having a pump does not exclude you from liver transplantation. I think what I've seen more commonly is that it is a living donor program. And in general, what I'll do for my patients is I'll work together with that transplant center to make sure that if I'm making any changes in the treatment regimen or anything like that, that goes hand in hand with what the transplant team want. Also, what we typically do is, which is a little bit different to Carole's case, but is that the liver pump is removed at the time of transplant. I think we're learning a lot more about how liver transplant plays a role in patients with liver metastatic colorectal cancer. I think Carole was a little ahead of the curve with her story. Definitely it was not something that I was seeing very frequently a number of years ago. I only had a handful of patients, and now it's increasingly becoming part of the treatment paradigm. And I think, again, we're trying to understand, how this all works together. Carole, you probably know a little bit more, though, about what the criteria they had for living donor or not. Yeah.
Dr. Connell, that was perfectly said. The only thing I would piggyback that with is, that I believe there are around 60 patients that have transplanted after CRC, which is a niche situation in its own. And maybe that's another webinar at some point. But I think it's just important, that said, to your point, Dr. Connell, that it's something that we are learning about. So great opportunity to have those conversations with your team. And I also would just also plug that interdisciplinary team, as to your point, working side by side with different, modalities of care, all intertwined in one, to make sure that the successes and the outcomes are what you're, striving for, and that your goals as a patient are heard. And so, I couldn't agree more.
Thank you both so much. I just want to point out we do have about 10 minutes left, so if you do have a question, please feel free to put it in the Q&A panel. I've got one more in here right now, and somebody knows their stuff. So for those who have had cholangitis from HAI therapy, is it not indicated to ever receive FUDR via HAI in the future?
So this is in general, if we begin to see elevations in terms of bilirubin, in terms of the liver enzymes, in the majority of patients, then we will not re-challenge with the FUDR treatment. So a significant rise in bilirubin is generally a situation where we would not re-challenge. If, for example, it settles down with drainage or not requiring stenting, I certainly have had patients where I have re-challenged with FUDR in the future, but I don't want to say that that's sort of the standard. I think that's something that's a very individualized decision, trying to understand the goal with the HAI therapy, how the patient was post cholangitis, the episode, or what exactly they needed in terms of biliary intervention. And it's definitely not a decision that I would make in isolation myself with a patient in the clinic room. It would be something that I would show at our tumor board to make sure that we're making the right decision for that patient.
Awesome, thank you. So I'm going to go to some of the questions I received via email prior to this webinar. How frequent are complications with the pump at trained centers that do these often?
So, I think with any treatment that we have or any procedure or intervention, there are common side effects, and then there are rare but serious side effects. And understandably, as patients, and particularly patients who are seeking a HAI pump, you're so well informed. And I always learn something for patients when they come to me in clinic. But the most serious complication can be biliary sclerosis, right? And I think that's something that we read about a lot in terms of the HAI treatment. In the beginning, when HAI pump was being used, the rates were much higher, 30, 40%. Now it's down to about 7, 8%. So it's down to single digits. And this is where, talking about earlier, holding the FUDR, it's having that experience to know that, seeing some liver inflammation is okay, but when to scale back or stop, and, not to overtreat the patient. But it's low rates of biliary sclerosis. I think that's the most serious complication, but, it's rare, but serious for patients. More common side effects can be some patients can have like ulceration. That's something else that can happen. So we also put patients on proton pump inhibitors. If you're having a lot of reflux or epigastric discomfort, I'd have a very low threshold to do an endoscopy. But I think, what I would say with a lot of the centers that are around the country, it's a lot of the fellows or trainees or the MDs have either trained through Memorial or they've observed at Memorial. It's a very tight network. We all know each other, and there's a lot of cross communication about patients to make sure that you're getting the best care, but also being practical and knowing that the care can be delivered closer to home. And so that being said, we also have a consortium. We meet once a month, and we go through some of these complex cases, or maybe where there's been complications or what to do next. And so I would give patients a lot of reassurance that care is being delivered very well at many centers around the US. And I wouldn't say that there's any significant difference between the rates of complications or not, depending on the hospital that you go to.
Excellent. Thank you so much. We've got time for just a couple more questions. Before we keep going, though, I'm going to try something new on this webinar. I do have a poll that I would like to launch. If you're still here and still watching, do me a favor, answer this quick poll. It's just 2 questions, but I will continue to go over some questions in the Q&A. So this should pop up for you on your screen. I have a question about cirrhosis. So what if the liver gets cirrhosis is the extent of that?
Yeah, so again, this is something that, we take into account, what is the goal of the treatment, number one? Is it to try to get a patient to resection or to get them from inoperable disease to surgery? Is it as a bridge to transplant? Or is it in a patient after liver surgery and we're doing this adjuvant or preventative treatment? So I think the exact application of the HAI pump is important to consider. As well as having like a hepatologist involved in terms of managing the patient's care. And if somebody has, Child PUA, or, that wouldn't be a contraindication to having the pump treatment. But again, it's within the context. I've also had some patients, and I say this to make this more informal, who've said to me, if they're already accepted for a liver transplant, why don't you keep treating me? Because that speeds me up on the list. And I'm like, I can't do that, but there are definitely safety concerns there. But it's really about getting the balance between the toxicity from the patient and also the goals. I think with the liver pump, it has, a very clear role for many patients, but there are also situations in patients where they have liver-only metastatic colorectal cancer where we do not recommend a HAI pump, right? And that may be in a patient who has like very extensive tumor burden in the liver. Perhaps they already have signs of like portal hypertension or back pressure on the liver, varices, things like this, or they might have ascites or fluid in the belly. So there's a happy medium in all of these scenarios, and it's really an informed decision with the patient and the caregiver, with the physician, to make an informed decision about proceeding or not. But I don't want to say that, when somebody comes to me in clinic, I always offer a HAI pump. There are definitely situations where even in patients with liver-only involvement, I would not recommend a pump. And I may perhaps, advise the patient to have transplant or Y90 for various different reasons.
Thank you. Are HAI pumps sometimes recommended for patients even if they have resectable tumors?
Yes, so we use it in patients who they can be operated on, but we're giving it in the preventative setting after surgery. So in a patient that it's been recommended in, it's usually a very defined course of treatment. It's typically given over a 6-month period. In general, I tend to treat maybe 4 rounds of the FUDR in a patient like that. But for example, if I see a patient who perhaps had like a colon tumor, within a year, they had their adjuvant Capox or Folfox, and they developed recurrence in the liver within a short period of time, if we can still technically go in and operate or remove that tumor, my concern is that this develops pretty quickly after having already a course of traditional preventative chemotherapy. So that would be somebody that I would recommend placing a liver pump as sort of a mop-up or preventative chemo after surgery to eradicate micrometastatic tumor seeds that are circulating.
Well, thank you. You mentioned Y90 earlier and the radionuclide, or not radionuclide, but spheres. Does Y90 prevent you from having an HAI pump? And what other procedures might prevent you from being eligible for an HAI pump?
Yeah, so no, it doesn't. I think what I would say is if I meet a patient who is making a decision between Y90 or HAI pump, like they're being offered the Y90 locally, and I think they're a good candidate for pump, generally my preference is to proceed with the pump treatment first and do Y90 later on. However, if I see a patient who's already had a Y90 procedure, again, there's been a huge advancement in terms of techniques with Y90 and any of these IR interventions. So they're now much more selective, right? So it's something that, again, we would consider in patients, but it would be presented at our tumor board to look at the scale of the Y90 that was done and the areas of tumor recurrence in that particular patient. But yes, you can do pump after Y90. And I've had some patients do very well in that scenario. But if I meet somebody at a decision point and I think pump makes sense, then I'll generally prefer to offer that first, because it's treating not only the visible disease in the patient, but also treating this micrometastatic disease, or what we don't see on the scan, which is why I would prefer to use it first.
All right, thank you. And I think we've got time for just one more question here. Thank you to everyone who's answered the poll. If you haven't, please take a moment to do that. And the final question I had that came in via email was, can you do histotripsy before and or after getting an HAI pump? And that's an uncommon procedure, or at least I have never encountered it in our time at CRC. So if you could let people know what histotripsy is as well, please.
Yeah, so histotripsy is really the new kid on the block, I would say. We didn't have it available at Memorial up until maybe 3 or 4 months ago, but I definitely had patients who were having histotripsy at other centers and then coming to me for pump treatment. Now we do have it available. It's basically like another version of ablation. It's using ultrasound technique and sound waves. So the way that I would word it to patients is that it's not a preclusion for HAI therapy. I've certainly had patients where, again, if I am concerned for micrometastatic disease or multiple tumors in the liver, my preference would still be to offer the HAI therapy first to treat the entire liver, and I may reserve something like ablation or histotripsy if there is maybe 1 or 2 resistant tumors. They can be done concurrently. I would also like to preface that, though, that I have not had a huge volume of patients yet with histotripsy and HAI therapy. I've only had a handful. So I think this is a watch this space, and it's something that we're going to learn a little bit more about. But in general, at the moment, and I'm speaking with my surgical colleagues as well, we view it in the same way. Would we offer ablation to this patient versus histotripsy?
Excellent. Thank you so much. And I had a short question come in, and you kind of touched on this earlier, so I'm going to go ahead and ask it if that's all right. Can a patient golf, fish, lift weights after an HAI pump installation?
Yes. Yes. So again, look, we're doing this because we want to get the scans looking better, but we also want to help the patient live their life and live well and live for longer and enjoy their lives. And it's in my clinic, I'm happy by nature because I'm seeing, very, very unfortunate cases, young patients, and I really want to help patients by doing the pump. And I feel like if I'm taking away a lot of the pleasures in life, then, I'm not just treating the scan, I'm treating the person. So I do allow my patients to take part in these physical activities. Generally, what I say to patients is in the beginning, And because it's, as Carole mentioned, it's just under the muscle in the wall, it can move around a little bit in the beginning. It can be a little bit swollen. You might have young kids, and a patient said to me yesterday, it seems like the pump is an attraction. The kid wants to kick it. Is wear a binder. So I usually have my patients wear an abdominal binder, or I tell like my female patients to use like more compressive gym wear, for example. And over time, you'll feel the pump, it's sitting there a little bit more, it's a little more firm in position, and then you can sort of push the boundaries more so. But I do allow patients golf. The main hard notes for me, I'll be honest with you, are the scuba diving because of the pressure concern with the pump, the hot tub during active treatment, because the heat can speed up the rate of delivery of the FUDR into the liver, which can cause a flare in the liver enzymes. But everything else within reason, you might have to modify slightly. We do talk about weight restrictions. Carole mentioned she's 4 kids. Are you going to lift up your child? Of course you are. Again, have a binder, be sensible. But I often get that question, because we talk about a weight restriction of like 15 to 20 pounds. In the beginning, you have to be mindful of that. But if I have a patient who has like a 30-pound toddler, of course I'm going to tell them, you can lift up your child, but just be sensible. And a lot of it has to do with the modifications, and the binder really helps, honestly, in patients. Carole, I don't know if you want to comment on that, what you were told, because we always have this debate back and forth as medical oncologists and surgeons, who allows what. So, yeah.
I know we're running out of time, Dr. Connell, but I would wholeheartedly agree with you. And the other thing that I would also add is taking your time into entrance back into your fitness experience. So that might look like yoga, like not powering right back into lifting heavy weights, because in the long term, there's other things that can come into management, like abdominal hernias and things like that. So I think with any other thing, it's all in moderation, to your point. And the lap belt was a lifesaver. Just having that binder, it helped me be confident and comfortable that I wasn't going to hurt myself. And then I was able to not restrict myself as much because I felt confidence. So, yeah.
Thank you both so much for taking the time to answer these questions. I'm going to move on because we are out of time, unfortunately. I always like to provide a little bit of information about how to get involved with Fight CRC. If you want to help distribute resources to people that need them, you can join our Resource Champions program. You can join our in-person events like Call on Congress or Climb for a Cure. You can apply to be a RAT, which is Research, Advocacy, Training, and Support. You can apply to our ambassador program, request resources from me to distribute for awareness, health fairs, or other events, or just reach out to us for other volunteer opportunities. We're always looking for people who wants to get involved, and we lean on our volunteers, and we couldn't do our job without them. So both Carole and Dr. Connell have volunteered their time today, just as an example of how important volunteers are to Fight CRC's mission. So again, thank you so much, Carole, Dr. Connell, for volunteering your time. I'd like to thank Intera Oncology for supporting this educational webinar. We know everybody's schedule is busy. Thank you so much for joining us today. We really appreciate it. This has been very informative about a very interesting topic that honestly I've learned a lot in this presentation as well today. So thank you both so much. I always like to end these with reading our mission statement. We are Fight Colorectal Cancer, and we fight to cure colorectal cancer and serve as relentless champions of hope for all affected by this disease through informed patient support, impactful policy change, and breakthrough research endeavors. Again, Carole, Dr. Connell, thank you both so very much for taking the time today. It was great to meet you and to get a chance to work with you.
Thank you, everybody. Thanks, Carole. Thanks.
Have a great day, everyone.